Um, so I'll give you indeed an introduction to the strategy. So let's see the cervical cancer strategy. We'll go over some of the modeling, and that itself will also then look a little bit at what happened with modeling for the older age groups. We'll touch clearly on supply because this is an issue that came up yesterday, and I'll show you some of the slides that were presented to the working group and the SAGE discussions in October last month. And then we'll end with going over the SAGE recommendations that came out, so that can kind of further lead to some discussions. So there's no need to say we have been talking about the cervical cancer. Here you see the wide variability that exists in the world. And I think that the main notion to show that there are regions where incidence of cervical cancer is extremely high, which is corresponding with Gavi countries. So this will go back to some of the concerns about how the current allocation is distributed of the vaccines. To other regions which are very low, some below this green line. So you see the green line of 4 and the red line of 10. You may remember those when we go further. So the discussion started 2 years ago about should we go for elimination, and one of the questions was what do we mean by elimination? It's clear elimination is not eradication, so we talk about interventions that will have to go on after elimination targets are being reached, and we realized we needed models to look at what is actually these levels that could be reached at the global level. So one thing we did was inviting all the groups that had models that could look at this issue. And there were kind of 3 main models that came forward. Number one, the policy model from Australia, the Harvard model by Jane Kim and others, the advice model we heard about yesterday by Marc Brisson from Canada. And then there was the spectrum model that is actually a model that particularly looks at HIV. So we're doing actually a specific modeling for HIV positive to see whether this group in certain countries, particularly in Africa, need additional vaccination and screening and what that could mean. So basically these 3 models were compared. And in the end, kind of people brought together many of the assumptions so that there is one kind of overall model that was used for the global modeling. We looked at many scenarios, and what I put up here are the scenarios that kind of in the end were the scenarios from, I think, 16 different scenarios that kind of made it into the final modeling. First, because modeling takes a lot of really energy, days of computers running, so we really couldn't do all the 16 all the time, but also because it became quite clear that some assumptions, some scenarios had huge impact and others started to have very marginal, if no impact. So what you will see in some of the models coming is scenario 1, girls only vaccination, scenario 2, adding a 1 lifetime screen. We put it here at 35-year-old, which is more for modeling purposes than clinically saying that's when it should take place. So please remember that. Scenario 3, adding a second screen 10 years later. And those were kind of the main scenarios. You will see some of the assumptions about ramp up, and this is about the screening. How quickly is it realistic that screening could be introduced in many countries that don't have it. For vaccination, we ended up using the 90% coverage for the girls. When you will see when we look at some of the issues with boys, we also use those same levels. Let's see what more to see. And then there was very important kind of assumptions about duration. So lifelong duration of the vaccine and 100% efficacy against multiple types. So to see what the maximum impact could be. So these are the scenarios. So here you can see in these screens We did the analysis for the low-income countries, which is the group in blue that have, on average, a very high incidence of, say, over 40, and the lower middle-income countries, who are already a bit lower, around 20 plus at the start, and to see how this would behave over the coming years. And coming years is basically a century. And so you see the blue line is kind of the variation with the different models also around these lines. And what you can see is that in the low-income countries, with vaccination only, we will not be able to go below this threshold of 4 per 100,000, which has been coming up as the threshold that with a scenario of 2 lifetime screens and vaccination is something that could be attained for the whole global level. So maybe that's a step that I will not get to otherwise. That's something that we did last year to kind of say, should we go for 10? Should we go for 4? Should we go lower? Lower than 4, clearly not feasible at the global level. 4 is just feasible, and 10 would be much less ambitious. So, but here you can see vaccination only in low and middle income countries would get us in 100 years below this threshold, but not in the settings that start with extremely high incident levels. When we add screening, you can see the effect. It comes earlier and it goes down. So that's the 2 effects on these curves, which coming earlier and going down here means millions of women's lives saved. That's important to remember. It's not just a little curve. And adding 2 lifetime screens makes the slope steeper and brings it even more forward. So what you can see from this is that between 1 and 2 lifetime screens added to vaccination, we think we will be able to cross this line of 4 per 100,000 also in the low income countries, but because of the variability, that's still not. There's a margin of error around that. That backs the question that it will be still a lot of work. So these are kind of the main models that underlie a lot of the decisions around, what should be in the strategy as the main recommendations. So here you can see. When we had done this work for a grouping, which in the end we are going to present in the global strategy of 78 low and middle income countries. Why we haven't added the other ones? Well, the high income countries, also because of the screening that has happened, etc., are far below the levels of these low and middle income countries in terms of incidence. So their levels are much lower, and they will all be able to reach the 4 per 100,000 threshold. So you can clearly see between the green vaccination only and the blue 1 lifetime screen and the red 2 lifetime screens, that volume, but the difference between the green and the red line, that's the millions of lives saved that can be reached by adding screening programs in the many countries. And here when we say screening, we say no pap smear, high-test DNA screening. That's what will be needed to attain this. On the right-hand side, you see the same graph, but then exposed in a way that I know Eduardo likes much more, in percentage of decrease of incidence, or you could also express it in percentage of decrease of mortality, for example. So you can see, when would you decrease your incidence by 85% with the various strategies, and the main differences is about timing. You could get to these levels, either 85% coverage or 4 per 100,000, but it's more about when will you be able to get there. So we have not talked about boys, but in the work that we did. Of course, we looked at, and this is all part of the sensitivity analysis, does it matter adding boys? And the same analysis had been done just the year before when we did the World Health, the WHO position paper, and looked at this question with SAGE, like, does it add a lot? And you may remember from then that WHO's position and SAGE recommendation was primarily the importance is vaccinating women. For the girls, 9 to 14, adding boys adds a very marginal part to prevention of cervical cancer. Of course, the focus on cervical cancer is part of why this answer is like that. So we come to the same conclusion. So here we looked at also at what would be adding boys mean for the curves. And you can see a little bit a pattern that we saw yesterday when we added the older women, is like there will be marginal differences. These differences are bigger in countries with higher exposure, higher incidence at the beginning than those who have lower incidences. But it's very marginal, and it's hard to see the difference between the lines. So this was the reason why, in the end, after the analysis, after this sensitivity analysis, the decision was that indeed the current recommendation of girls only would stand for the elimination. We did the same for older women. Now, we used the half faster approach, maybe up to 25 years of age, so we didn't do 45 years of age. But I think here, from this graph, you get the gist. Like, it adds a little bit of speed, but it doesn't, of course, the final line is not changed. That's not surprising. And it's a small contribution, but of course, because it comes at a very high cost, it's not. It was not maintained in the current strategy. So what you can see here is that this did not use 1% coverage. It used 90% coverage. So a catch-up, as you can see, this one was also used with 80%. So we tried 80%, 90%, what does it mean? And so here the 80% was done for boys and girls. And then we looked at what's the difference if we add to that a catch-up to 25 with 80%. So again, as you see, very limited additional value. So all of this kind of confirmed this work, the targets that we had been proposing, that partly went into the models and then later were confirmed by the models, and that we now have also discussed with all countries in the region. And so these will become the 90-70-90 targets, partly chosen this way because they remind some other people in the HIV field of the 90-90-90 targets that they have, and that seem to be useful in practical planning and remembering what we are waking up for in the morning and start working for. So, and this threshold of 4 per 100,000 is being maintained. And as you can see in the 70% screening, we talk about high precision test. So this is short for DNA testing, and this is something that basically we say over the next 10 years, countries that introduce, countries that evolve their programs will need to switch to these high precision tests. On vaccination, the 90% coverage was, of course, discussed a lot in all the regions. And we will come to a slide of why that's quite controversial. We also talked about, should we change it? Should we bring it down? And finally, the answer by many countries was no. I mean, it doesn't make sense. And it doesn't make sense because most of us are reaching 90% coverage with our measles. And I was saying the other day, yesterday, Germany said we have to make measles mandatory because our vaccination levels are lousy, 92.5%. And this is close to a public health disaster. If we can do that, why can't we reach 90% for HPV? If every country in Europe reaches 90%, so 90% coverage is not a problem. It is reaching it for HPV. And part of that, I mean, you can argue about it, is about, well, how urgent is it? And I think for policymakers, it's not urgent. We exclude HPV from a lot of the discussions. In one of the discussions we said is like France, the minister said, problem they have with public perception about the vaccine is that we say it's good to do the vaccine, but it's not mandatory. People think if it's not mandatory, it's optional, it's not important. So I therefore changed the perception. As of today, 11 vaccines are mandatory. That's what she did a year and a half ago. And the 11 didn't include HPV. And so, here is France, 90% coverage of most of its vaccine, HPV 36. So I think there's a perception issue, and countries having also very low coverages were saying, yes, we need to do something, so let's keep the 90%. We also say if we don't keep it, if you are in Uganda, well, but don't start, well, not don't start working, but you will not reach elimination. That's very clear. There, you can only reach it if you reach 90% coverage. Of course, the story actually is very different in Australia. They are close to reaching the 4 per 100,000, probably in a couple of years. And they wouldn't need 90% coverage, but they do. So, Ludmila just said, like this is, and Eduardo said yesterday, the world has decided on this elimination. Well, we haven't decided yet. It's going to go to the executive board now in January, and in May, all your policymakers and those from Africa and Asia will come together and decide, shall we accept this? One of the reasons I think I hopefully will accept this, they will have to look at what are the costs of this, and that's where they were looking at, well, what are we being asked to do? And there I do think they will see the huge cost that will come from the screening, and probably the somewhat more moderate costs coming from the vaccination. Vaccination is the easy part to this whole strategy, actually. So I think that's where partly the issue will be is, if they only have to vaccinate the girls and can start with that and then focus their attention on screening programs, they have a lot to do. Not to talk about treatment, which will be a huge issue. Now, the treatment of precancerous lesions, that's part of the, that's a must. You screening is only as effective as the treatment that you give. But this also includes 90% treatment of invasive cancers. Now, invasive cancers will not contribute to cervical cancer incidence. So in a way, it will contribute to an overall goal of reducing mortality, but it's not factored into the numbers about the elimination. But that will be a big task for many countries to build those facilities to start treatment, radiotherapies, chemotherapies, etc. So now a little more look at the vaccination. So in the strategy, we mentioned 3 key factors for both vaccine introduction and reaching high coverage. So supply. I think the comment made yesterday that this is a transitionary issue is very true. It just comes for this work at a very unuseful time, let's put it this way, because the strategy is going to focus on the next 10 years. That's when we need to do the work, and then we will see the effects over the next century. And if the next 10 years, half of that time are determined by vaccine supply challenges, that is, of course, quite unfortunate. So we will get a lot of comments on that as a community. And again here, yes, we can point to manufacturers, but it's a joint responsibility of those who do the forecasting, those who do who thought how fast this would go. And so we will see that actually the supply issue is you can say it's a sign of something very positive. Namely, there's a huge demand coming in the last couple of years from the whole world. So that's the good news. The bad news is we have to deal with this. So vaccine price continues to be an issue. Particularly for the middle-income countries. Gavi countries get support, middle-income countries don't get that support. For them it means a lot, and so we see this back in some of the data. Delivery costs, that's another part of the cost, are important. School vaccination in many of the lower-income countries is not something they normally do, so it costs more. But those are often then discussions that end up affecting the coverage levels, because when the costs are very expensive, and we see this now in Africa in some of the Gavi countries introducing, they start to tinker with the introduction, with the delivery strategy, make it cheaper, and then the coverage levels goes down. But that's what these countries have to do. So overall coverage is mostly impacted by bad planning, insufficient communication, sometimes insufficient crisis communication. We see a lot of that in the introductions, and I'll show you some data later on to show that back. So some of the good news is we celebrated last month in October, we celebrated that 100 countries have now introduced. So we are over half of the countries, 52% of the countries have introduced. So that is very nice. It's yes, HPV is lagging behind, but also kind of the speed of introduction compared to Rota PCV is kind of picking up. That is very good. But some of the countries are the smaller countries that have introduced. So actually, we are only at about 30% of countries, 30% of the population in our target group, 9 to 14, live in countries where the vaccine has been introduced. So at best, we have a global coverage of 30% if all the girls take up the vaccine. That is also not the case, and we'll come back to that. Here you see a little bit by region what you saw already, and by income grouping. And I think the main thing here is, the low-income countries continue to be low. So this is where we need to increase. And these are the countries where we showed at the beginning that have all these extremely high incidence. So basically, we've introduced where it has an effect, but it has less effect, and we have not yet introduced where it will have a huge effect. Middle-income countries and upper middle-income countries are mainly the countries in PAHO that have introduced, so they have a negotiated price of $9. This is why those countries could introduce rapidly. So the other group I was talking about is particularly upper middle and some low middle income countries who typically pay now around $15 on average. So that price has come down. It's going down continuously, but some pay far more and end up and still pay up to $60, $80. Here I've added boys vaccination. So what you see here is that in the last couple of years, a big number of countries have added boys. We just heard UK added last month, but this year several more were added. We see mainly in the high-income countries, but we start seeing it in some of the Latin American upper middle-income countries as well. So this is partly good news, but when we come to supply, we will tell you why it's not so good news as well. This is vaccine estimates, coverage estimates. So this year, for the first time, we made WHO UNICEF estimates for HPV. To identify coverage for HPV is slightly more complicated than for childhood vaccines. That's why it has taken us and many countries many years to find also the methodology to do this. This is probably we will refine this methodology over time, but by what you see here is at least we have one methodology that we've applied to many countries. If you don't find your country, particularly in Euro, that's great news. Please go back to your policymakers and start reporting to WHO, because the biggest non-reporters are unfortunately high-income countries who do have excellent data, but they just don't report to us. But the pattern we see here is very obvious, is very clear, and this is also how we discussed this 90% target. The question, is 90% coverage possible? Well, you look at this and you say, yes. Every region, without exception, has countries that reach 90% coverage. Maybe with the first dose, second dose is bigger, so yes, the typical thing for HPV is higher dropout. 10% dropout is good. We have dropouts of 50% in some countries. But we can also see the inverse. Many countries that have very bad coverages, and 5% is very bad. On the low side, we must say there are some countries like Indonesia who just started. They report as introduced subnationally, and they started in Jakarta and 2 cities. So yes, they have 0.5%. So that's not the same. But other countries, Armenia, unfortunately, kind of introduced in most of the country and did not get very high. And countries in the Caribbean particularly tend to do very bad. These are very small populations, but the coverages are not good. So I think this is the picture we have everywhere. It is hard and it's possible. So those are the two things. So here we see where we are. I mean, I tried to start with Belgium because that's where we are. In Belgium, 67. This is a data point we got, which is actually not that bad, 67. But again, it's from the middle downwards, and it's typical when we say 67 for HPV. In this world we say it's not bad. We should be saying, and as of May next year, we will be saying it's very bad. Belgium, what are you going to do? Netherlands, my country, is a bit lower. Where is it? 42, 52. So, we have a lot of work. And in a way, I think also that's the nice thing about the cervical cancer strategy, the elimination strategy. It's a lot of work for low-income countries, but it's also a lot of work for high-income countries. And everyone has something to do. And I think what the high-income countries have to do mostly is around vaccination, many of them. So the supply shortage. We emitted this global market study last year on HPV. We worked together with Gavi, UNICEF, manufacturers, everyone, to put that picture together, because we were starting to get signs that the market was kind of short. Now it's short, meaning the situation is quite tight. Basically, when to put it in perspective, in general, ongoing programs can go on as they can. We heard, for example, from Spain that, well, yes, they can go on, but actually they don't have enough for some of the older groups. So in some parts, they have to say temporarily we may focus on the girls. We had that in South Africa, and they may have to suspend one group for 1 year, and then hopefully they get a vaccine after. So some programs are affected, but in general, most programs are advancing the way they are. In the Gavi countries, that's where things got most noticeable. And Gavi wanted to introduce in about 20 countries and had to tell these countries, well, you have to introduce maybe a year later, because the first year we don't get it, the second year, yes. And they had to take away these multi-age cohorts. So this was a recommendation from WHO that Gavi now supports. Countries for free can get 6 extra cohorts, say 10 to 14, and add that to their introduction year. That added a huge volume. So we have suspended that within Gavi already last year. But still, all countries that planned could go ahead. So for this year, we could, let's say, kind of continue to move, but without the MAC. We saw in some middle-income countries new introductions this year. We had 5 introductions, so that's good news. These were, of course, planned 2 years ago and purchased 2 years ago. So, but one country that wants to introduce couldn't do so, and I think we'll start seeing that. So basically, the supply shortage is starting to hit us now. As you can see here, we for the coming years, we basically think, if you compare to the current situation in the short term, which is 1 to 3 years to 23, at best, which is the green dot, we will kind of increase by 30% the amount that is available, or it could be a little bit higher. Maybe that's the green dot. The red dot could be a bit lower, and if things don't materialize, we could stay at the same. But in the midterm, we expect things to get better, and that the production will go up by 2 or 3 times. And in the longer term, it should be even much better. So that's the overall situation. So here you see how we make demand forecasting. A reminder, this is an unconstrained forecasting, which means if all supply were there, which countries do we think are ready, willing to introduce, and how does that translate into demand? So right now we are around 50 million doses that are kind of being used per year. That's the darker blue, and that's the base that will only grow slightly with population demand, population growth. The light blue is countries that come in new, and that come in with their routine cohorts. So, you can see we think that many countries will introduce in the coming 5 years, and then we have some bigger countries that we expect to come on board with some big jumps, and that by the end of 2030, all countries have introduced. Now, this is based on assumptions also, of course, a lot of assumptions. But one of the assumptions is the elimination strategy, which asks every country to introduce, if possible, in 2020, but the latest in 2030. So we've kind of spread them out this way. The yellow is the max. So by adding these 6 cohorts at the beginning, and here we're still talking about 9 to 14-year-old girls, you see what happens to the demand. And that's partly creating the current problem. And but also to think what would happen if you add 1, 2, 3, or 10 or 20% of adult women to this, you would get huge spikes. So again, we then started to work on scenarios like, okay, with that demand scenario, what would happen with various scenarios for certain doses. So you can see blue is 2 doses, what we do right now. But if we don't do these max, what would happen? So the light blue, slight different curve. What would if we do 1 dose? So the 1 dose assumption here was if there's evidence by, say, 2022 and there's a change in recommendation, what would happen to demand? So you see here demand will go down, but not before 2021, let's say. So it would have limited effect in the coming years, etc. So these, and then we had extended intervals, so the green one, and some others. So here you can now see what the demand-supply balance does. And so in this, here you see these scenarios being played out, and the red means, there's more demand than supply, and hence there will be countries that cannot introduce. And the one scenario that stands out as potentially alleviating the supply situation somewhat is the extended interval. We had 3 years, it could be 5 years, but so it's mainly from this analysis we said none of the other scenarios would really have a big effect in the short term. The extended interval does. We think that in the midterm and long term we are fine. This is the base supply, meaning the best scenario, all new producers that may come on board, the new planned production by the current manufacturers will all go as to plan. If that doesn't happen, if there's a flood somewhere in a factory plane or in a place where a factory is being placed, we could be more on the side of the low supply, and things could be worse also in the middle or longer term. But for now, we think the base supply is our default. This is just to say what happened with, if we are in the red and we continue with current work, what would this actually mean in terms of countries that cannot introduce, and how many deaths would not be prevented? Because every 14-year-old girl that is not being vaccinated basically goes out of the eligible age group and starts to have sex. So even if she would be vaccinated later, it would be less effect and would lead to a death in future. So you can see going on with current, 140,000 additional deaths, etc. So we looked at it this way to see where are the public health priorities. If we do no max, situation is better. Only 9 countries cannot introduce, and it leads to 20,000 deaths, etc. And the extended interval again is the one where, with proper management, maybe we can prevent a lot. So then there was the issue of boys. So we realized that at the moment about 18% of global demand is used for boys, and that you will see later. On the one hand, could have prevented a lot of cervical death, which it clearly doesn't do for boys itself. So But it's particularly the rate of increase of male vaccine introductions that make us think that if that continues as it does, then we are, and if the supply situation doesn't get better, really these introductions for boys start to eat into lives we can save for the girls. So therefore, you can see here, if we continue with the current trend and looking at some of the countries, then it would basically prevent, 12. If we added over the coming 3 years boys vaccination, we could not introduce in 12 Gavi countries, and that can be translated into a number of deaths. So these were the data that went into the SAGE. The SAGE looked at barriers, looked at the one-dose evidence, interval evidence, etc., to be able to say, can we make some alternative recommendations? What should we actually say? And then it used these scenarios that I showed you. So just to say on the one dose, this is something you're all aware of. Some of you here in the room were with us, including John Schiller, who I think we all have to applaud, because it's the second day in a row that at 3 p.m. he's listening, or he's trying to stay awake when I talk, I suppose, because you've heard this a couple of times. So we looked at one dose of efficacy. At the moment, the conclusion is it's very promising evidence, but it's of low quality because they are not RCTs, but they are derived from data. Some of the data were RCTs in the past, but let's say that's not how the individuals in those data sets were kind of selected. And therefore, SAGE kind of decided at the moment it's too early to move to a one-dose recommendation. We did have an extensive look at all the trials that are being planned, or planned that are actually already ongoing, recruiting, etc. So these are the ones in green, many in Africa and others in Latin America and Costa Rica. So mainly what we see here is that intermediary data will start coming in starting, let's say, in 2021. And then the yellow stars are kind of final data and final evidence should be coming towards 2022-23. And so we basically, again, expect that by then we can see what the decision can be on one dose. So SAGE, therefore, said we stand by the recommendation that we had last time, and there's no need to change the position of WHO as we had in 2017. That actually said 9 to 14-year-old girls, 2-dose schedule. And we looked at interval data, but we realized we had already a quite permissive, if you want to use that word, interval recommendation, 6 months minimum. That's very firm. But we basically said there's no maximum. 12 to 15 is recommended. So that was the previous recommendation already. No change for older age groups, 15 years and older, or HIV positive, needing a 3-dose. There was also a reiteration of the safety and efficacy of all different products. Why was this done? Because one of the assumptions around supply is that if we use all available products, then we can scrape by and introduce in many countries. It's very important that also the countries see that what we believe is all products are very good for cervical cancer prevention. If no one starts using the new vaccines coming from China, which are bivalent vaccine, then we're not helped. So it is therefore very important that the public knows about this and that the professionals also know this. So with the concern about the supply situation, we did 2 things. We will come to what alternative strategies are being proposed, but one thing which is in a way a non-strategy is actually saying, please don't do the following things. So the MACs, which in principle we stand behind, the MAC doing a catch-up up to 14, at the moment, let's not do it, because introduction in every country is more important than the MAC. But in a way, not as important, I would say, is gender-neutral and older age group vaccination. Please pause your program. So I use the word pause, which is not here, but that's the word you will probably see in the way the SAGE recommendation is being it will be published next week. So here it says postpone, temporarily postpone, and one of the question is, are we talking to countries who are planning to do this or to countries who are doing this? The language suggests that to some degree we say, please pause your program. And it's partly based on this, the number of vaccines needed for each girl and each boy. We were given this data, you need 78 vaccinations in Uganda to save one HPV-related cancer. Already 560 in Canada for girls, but for boys it's 10 times more to prevent one cancer, and for middle-aged adults it's even much more than that, over 8,500. So then the alternative strategies were basically around two things. If you introduce and you want to maintain some of the advantages that MACs offer, vaccinating women close to sexual activity, 13, 14-year-old, you can do that by choosing a higher age group. So start vaccinating at 13, 14, and maybe later on you could move down to 9 years of age if there's vaccine available, and you do a kind of intermediary catch-up. And the other one, and that is probably the one more important, is that extended schedule. So it remains a 2-dose schedule. There needs to be commitment to find the girls for their second dose, but we could start with an extended interval of 3 to 5 years, and this is something that would really help the global supply situation or allow countries to introduce. So this would constitute off-label use of the vaccine, but we, SAGE thought that really one dose, there's evidence to support this. One dose is really better than no, and we have a lot of evidence to show that. Of course, the promise that one dose may be sufficient is like a thought for the end. And at this age group, there's low risk of exposure. Now, with this strategy, we really recommend you vaccinate early at 9 years of age, so that the second dose that comes at 12, 13, or 14 can still be before sexual activity for most girls, so there's limited risk. And then SAGE calls on WHO and the partners to have a dialogue on global access to the vaccine. So I think we will be, you saw the global market study. We've already started to work more concertedly on this. I think we will ramp up this issue and have this dialogue with all partners, which also means with countries. So it's not excluded that we will place a call to the minister in the Netherlands and say, well, you just published that you will introduce in 2021. Are you sure? Shouldn't you be thinking about 23 or 4? And so, how exactly this works, we don't know, because we haven't done that. But that's an interesting discussion. So basically, I think I've already given my key messages. No change in policy, the 1+1 schedule, and postponing male vaccination and adult positive vaccination. So just to say, I did a bit of graphs, the math, and if in China, US, and India, 1% of the women between 20 and 45 do HPV vaccination each year, that would be around 13 million doses. So 13 million is basically 1/3 of the current situation. So for every 1% of women that we currently invite to take up the vaccine, it is the whole of the amount that the Gavi countries have at their disposal at the moment. So that's the challenge we face. We hope this will be over soon, but that will take 2 to 4 years. Thank you.
Thank you.